Bismillah ar-Rahman ar-Rahim. This is Dr. Ayman Salahuddin Amir, Associate Professor of Human Anatomy and Embryology. In this lecture, we are going to learn about the anatomy of the cerebellum and the vestibular pathway. By the end of this lecture, you will be able to describe the anatomy of the cerebellum. You will know the position of the cerebellum, its parts, and also the cerebellar nuclei. Also, you'll be able to recognize the different components of the vestibular pathway and how to interpret the anatomical facts and their major clinical applications. For example, the cerebellar lesions and cerebellar ataxia. The reference book used for this lecture is the First Aid for the Basic Sciences. So let's start learning about the cerebellum. The cerebellum is located behind the brainstem. This illustration shows the position of the cerebellum. This is the brainstem. It's made of midbrain, pons, and medulla. And the cerebellum is located on the back or behind the brainstem. The cerebellum is divided into three parts: anterior lobe, posterior lobe, and flocculonodular lobe. If you look at the cerebellum in the axial plane, you will be able to see a different classification. The cerebellum is divided into the midline vermis, the intermediate paravermis, and laterally the cerebellar hemisphere. So this slide shows you two pictures of cerebellum. Here, when you look at the cerebellum in a sagittal plane, you can see anterior lobe, posterior lobe, flocculonodular lobe. But if you look at it in axial plane, you can see the vermis, paravermis, and the cerebellar hemisphere, which is located most laterally. The cerebellum has primary fissure separating between the anterior lobe and the posterior lobe, and it has a secondary or posterolateral fissure separating between the posterior lobe and the flocculonodular lobe. Note that there is another fissure called horizontal fissure. It is located within the substance of the posterior lobe of cerebellum. When you are studying the cerebellum, you learn that there are three important things repeated. So the number 3, keep it in your mind. The cerebellum has 3 lobes: anterior, posterior, flocculonodular. It has 3 major parts: midline vermis, intermediate paravermis, and cerebellar hemispheres. It has 3 major fissures: primary, horizontal, and posterolateral or secondary fissure. It has 3 cerebellar peduncles, as you will see in the following slides. The 3 cerebellar peduncles are superior, middle, and inferior. It has 3 functional subdivisions, and these 3 functional subdivisions are the vestibulocerebellum, spinocerebellum, and cerebrocerebellum. This slide shows you the 3 parts that I just mentioned: vestibulocerebellum, spinocerebellum, and cerebrocerebellum. The cerebellum acts and operates at unconscious level. That means you are not aware of what the cerebellum is doing. It does it without your actual will. You don't do it voluntarily. No, the cerebellum does it without your voluntary control. So what is the cerebellum doing? The cerebellum has 3 major functions. It acts to maintain the equilibrium or balance and posture. And for this part, the flocculonodular lobe is responsible for taking care of maintenance of equilibrium and posture. This part is called vestibulocerebellum or archicerebellum. The word archicerebellum means that's very old. It's like ancient. Why? Because this vestibulocerebellum is the first part that starts in development in the embryonic life. so it's very old in age. The second part of the cerebellum is the spinocerebellum, and the spinocerebellum is also called paleocerebellum. It includes the vermal and paravermal zones. This spinocerebellum is responsible for the maintenance of muscle tone. The word paleocerebellum means it is old, but it's not as old as the archicerebellum. So the oldest is the archicerebellum. The next in development is the paleocerebellum. The most recent part of cerebellar development, that means the parts of the cerebellum that develops lately in embryonic life, is called the neocerebellum or cerebrocerebellum, which includes the cerebellar hemispheres. The cerebrocerebellum or neocerebellum is responsible for coordinating the voluntary motor activities, like the motor skill learning. For example, when you try to ride a bike for the first time, it takes time so that you learn this technique of how to control the bike, or if you are driving a car. But after you learn it, the information is stored in the cerebellum, and then the cerebellum will take care of everything you do when you are riding a bike or driving a car or typing on the keyboard of the computer. These skills will be done automatically without your conscious. I mean, you can do it while you are talking or drinking or eating. So actually, it will be automatically done because the cerebellum will learn the knowledge of how to do it and keep it stored there, and then will coordinate this voluntary movement automatically. This slide shows a section taken in the plane of the superior cerebellar peduncle. This is a superior cerebellar peduncle, and this section was taken to show the deep cerebellar nuclei. The deep cerebellar nuclei, they are collections of gray matter positioned within the white matter. So the cerebellum structure is gray matter outside, it's a cerebellar cortex, then white matter. Also, there is deep cerebellar nuclei. It is deep nuclei made of gray matter. These nuclei are four in number, starting from medial to lateral: the fastigial nucleus, the glucose nuclei, the emboliform nucleus, and most laterally, the dentate nucleus. The dentate nucleus is the largest one, and as you see, it has many corrugations similar to the shape of the teeth. So that's why they call it dentate. It's like several teeth present there. These deep cerebellar nuclei are very important in their function. The deep cerebellar nuclei, all of them, receive input from the Purkinje cells in the cerebellar cortex. So they receive the input from Purkinje cells in the cerebellar cortex and send the output from the cerebellum through the superior and inferior cerebellar bundle. So this is the superior cerebellar bundle. The dentate nucleus sends the output to coordinate voluntary movements. That's why the dentate nucleus is considered a part of the cerebrocerebellum, because it controls the voluntary movement. It helps to coordinate it, to make the voluntary movement in a smooth, coordinated pattern. The interpositus nuclei, which include the glucose and the emboliform, together we call it interpositus nuclei, they send the output to control the muscle tone. That's why the interpositus nuclei are considered a part of the spinocerebellum that controls the muscle tone. The fastigial nucleus sends output to control the balance and posture. That's why it's considered as a part of the vestibular cerebellum. In addition, it also sends output to control muscle tone. That's why it's also considered as a part of the spinocerebellum. So the deep cerebellar nuclei, they are having very important functions. As you see, the vestigial nucleus, it's the only one that is having functions shared in two things. It is doing the control of the posture and balance as a part of the vestibulocerebellum, and also it is helping in the control of the muscle tone. That's why it's considered also as a part of the spinocerebellum. This slide shows you the contents of the cerebellar peduncles. The cerebellar peduncles, they are three: superior cerebellar peduncle, middle cerebellar peduncle, and inferior cerebellar peduncle. The superior cerebellar peduncle connects the cerebellum with the midbrain, and it has input or afferent to the cerebellum. When I say the word input, it means afferent, that's fibers going into the cerebellum. These fibers include the ventral or anterior spinocerebellar tract, the rubrocerebellar tract, tectocerebellar tract, and the output or efferent, the fibers that are going out from the cerebellum, includes the dentato-rubrothalamic tract and the interpositus rubral connections. In regards to the middle cerebellar peduncle, this peduncle is connecting the cerebellum with the pons. It contains input or afferent only, the fibers that goes into the cerebellum only. So it has one tract which is called the pontocerebellar tract only. The inferior cerebellar peduncle, it's connecting the cerebellum with the medulla oblongata. It contains input or afferent coming from the dorsal or posterior spinocerebellar tract, plus the cuniocerebellar tract and the olivocerebellar tract from the contralateral inferior olivary nucleus, in addition to the vestibulocerebellar tract. All of these are input into the cerebellum. The output, the efferent going out from the cerebellum through the inferior cerebellar peduncle, is the vestigiobulbar tract and the cerebellovestibular tract. This slide shows you the connections in a simplified way. So it doesn't show all the details that I mentioned in the previous slide. What you will see here, you will see the cartoon of the cerebellum. This is the cerebellum connected to the brainstem with three peduncles: superior cerebellar peduncle, middle cerebellar peduncle, and inferior cerebellar peduncle. And here are the structures of the brainstem. Note that the dentate nucleus is illustrated here with the teeth-like corrugations. We'll start from here. The dentate nucleus projects, that means it sends fibers to the midbrain to reach to the red nucleus and then goes to the thalamus. So this projection is called dentato because it arises from the dentate nucleus, rubro because it reaches to the red nucleus, thalamic because it reaches to the ventrolateral nucleus of thalamus. The dentato-rubrothalamic tract runs in the superior cerebellar peduncle, and it reaches to the contralateral side. That means it is reaching to the opposite side. The word contralateral means opposite. So if this is from the right side of the cerebellum, it will go to the left red nucleus and left ventrolateral nucleus of thalamus. Thalamic projection comes from the thalamus to the primary motor cortex in the same side, and then from the motor cortex it projects to the pontine nuclei, and from the pontine nuclei it projects via the pontocerebellar tract. Here is the pons. From the pons, this tract going to the cerebellum, it's called pontocerebellar tract. It runs in the middle cerebellar peduncle to reach to the contralateral cerebellar cortex. So if this is the right side of the pons, the fibers will go to the left side of the cerebellum. That's why we say it is contralateral. The projection from the pontine nuclei through the middle cerebellar peduncle reach to the contralateral cerebellar cortex. And these fibers are called mossy fibers. So it's one type of the fibers called mossy fibers, as you learn later on. There is another type of fibers called climbing fibers. The climbing fibers, they arise from the inferior olivary nucleus in the medulla oblongata and project through the olivocerebellar tract to reach to the inferior cerebellar peduncle and then to the contralateral cerebellar cortex. So again, if this is coming from the inferior olivary nucleus on the right side, it will go to the left side of the cerebellum and synapse on the Purkinje cells. From the Purkinje neurons, the cells project to the deep cerebellar nuclei. This slide shows you the blood supply of the cerebellum. It's very important to understand from where the cerebellum gets its blood supply. It comes from three paired arteries: the superior cerebellar artery, anterior inferior cerebellar artery, and posterior inferior cerebellar artery. The superior cerebellar artery supplies the superior surface of cerebellum, the superior vermis, the deep cerebellar nuclei, especially the dentate nucleus, and the superior cerebellar peduncles. So again, the superior cerebellar artery, from its name, it supplies what? It supplies the superior surface of the cerebellum. Also, it supplies the superior vermis and the deep cerebellar nuclei, especially the dentate nucleus. In addition, it supplies the superior cerebellar peduncles. The anterior inferior cerebellar artery, from its name, it's supplying the anterior part of the inferior surface of the cerebellum. So what is there? You'll see the flocculus and the adjacent regions of the anterior part of the inferior surface cerebellum. Also, the middle cerebellar peduncle is supplied by the anterior inferior cerebellar artery. There is an important artery called the internal auditory artery. This internal auditory artery is a branch from the ICA, or the anterior inferior cerebellar artery. It supplies the inner ear. Supplies the inner ear, or the labyrinth. The posterior inferior cerebellar artery. Posterior inferior cerebellar artery is supplies the posterior part of the inferior surface of the cerebellum, from its name. In addition, it supplies the ventral and medial sides of the dentate nucleus. So the dentate nucleus, because it is a very large nucleus, as you have seen in the previous slides, it receives dual blood supply. It receives blood supply from two arteries: superior cerebellar artery and the posterior inferior cerebellar artery. They both supply the dentate nucleus. The posterior inferior cerebellar artery supplies also all the other deep cerebellar nuclei, in addition to the inferior vermis, cerebellar tonsils, and the inferior cerebellar peduncles. Please note that the superior cerebellar artery and the anterior inferior cerebellar artery both are branches from the basilar artery. The pica, or the posterior inferior cerebellar artery, is a branch from the vertebral artery. In this slide, we are going to identify the signs of cerebellar dysfunction. So let's learn about what will happen if there is a cerebellar lesion. Cerebellar dysfunction will show in several signs. These signs, all of them are in the ipsilateral side. So if we have a lesion in the right half of the cerebellum, it will show signs on the right side of the body. These signs include disequilibrium, that means loss of balance, with a tendency to fall towards the side of the lesion, in the same side of the lesion. The patient will fall on the right side if the right side of the cerebellum is affected. The second thing is the dyssynergia. Dyssynergia means loss of coordination. The patient cannot coordinate its movements. I mean, the patient will not be able to coordinate the movement he is doing. it includes several terms. So I'm going to give you the meaning of each word. Dysmetria. Dysmetria, from its name, it says this means it's not accurate. Metria is the lens. For example, if you put an object in front of the patient, if you give him a pen and put it in front of him and ask him try to reach to that pen and hold it in your hand, you will see that the patient who has cerebellar dysfunction will not be able to reach the target correctly. If the pen is in front of him, his hand will go further away from the pen and then away from it on the right side, on the left side, and do several targets, but it will not reach to the actual structure that you are acting. So if you are asking him to reach to the pen and hold it, the patient will not be able to reach the pen and hold it in one trial. He will try several times away from the pen, and then he will reach to the pen. And these tries are actually called dysmetria. He doesn't have the adequate metric measurements. If you are normal, you will know the distance and put your hand directly on the pen and hold it accurately. But since this person has loss of coordination, he will not be able to reach to the target directly. The second thing is the intention tremor. Intention tremor, these are involuntary shaking movement of the hand when he has the will of action. So if you ask him to hold a cup of water, he will hold the cup, but since he can't coordinate the movement, his hand will be shaking so that the water will spill on himself. So it is called action or intention tremor. He will not be able to hold a cup of water in his hand steady. No, it will shake, vibrate, and he will spill the water on himself. The other loss of coordination is called dysdiadochokinesia. Dysdiadochokinesia. This term means inability to alternate contraction between antagonistic muscle groups. So if you ask the patient to do pronation and supination of his hand, he will not be able to do the pronation and supination. He will do flexion, extension, medial rotation, lateral rotation, but he will not reach the actual performed task, which is doing pronation and supination. There is nystagmus. Nystagmus means involuntary movement of the eye. So his eyes will be moving in a shaky manner. And the person, when you ask him to look at the side of the lesion, you will see the nystagmus more prominent. That means it will be more clearly evident when you ask the patient to look at the side of the lesion. So if the lesion in the right side of the cerebellum and you ask the patient to look at his right side, then you will see the eyes are going back and forth making this shaking movement. So the eyes are not looking steady, they are shaking. Explosive speech, it's a type of ataxic dysarthria. Dysarthria means inability to articulate the words correctly. And it is explosive speech because the person will talk in a specific mode and all of a sudden he will change that tone. So talk slowly and all of a sudden it goes up. So it's actually not in the same tone. It is explosive, goes up and then calm down. Explosive speech. The person will have truncal and gait ataxia. The word ataxia means the inability to have a fine control of the voluntary movement. So this is ataxia. When the patient has gait ataxia due to cerebellar lesion, the gait is uncoordinated and wide-based. So the patient will move as if he is having alcoholism. If he has been drunk due to alcohol, the pattern of gait is called drunken gait. That means the person is walking, swaying to the right and to the left, and with tendency to fall to the same side of the lesion. So it's called drunken gait. Also, there will be decreased muscle tone, hypotonia. The lesions of the cerebellar hemispheres will cause ipsilateral cerebellar signs. Again, I say it is ipsilateral. It is in the same side of the lesion. If the person is having a lesion in the right side of the cerebellum, all the signs that I mentioned will be shown in the right side. His right hand will have this action tremor, and he will also have all the findings in the right side, losing the balance to the right side, tendency to fall to the right side, nystagmus more prominent to the right side. So that means it's all to the same side of the cerebellar lesion. If the patient has a lesion in the vermis, it will cause truncal attacks. That means he will not be able to hold his trunk steady, but it will be swaying to the sides. Now let's look at the vestibular system. The vestibular system, it's important in the body because it takes care of three things: maintenance of the equilibrium or balance, coordination of the eye movements, and maintenance of the head position. The vestibular system senses the position of the body in space. By maintaining the equilibrium, the vestibular system will regulate the muscle tone of the anti-gravity or the extensor muscles of the trunk and limbs to keep the posture and balance of the body. This is done by a specific tract you have learned before, which is called the lateral vestibulospinal tract that reach to the extensor muscles. The second function of the vestibular system is the coordination of the eye movement. This is done when you are rotating your head, for example, and you are keeping your gaze and you are looking at a specific object in front of you, and you need to fix that object on the retina so that you don't lose your focus on that object. So it's a kind of reflex. It's called vestibulo-ocular reflex, using the vestibular system affecting the ocular muscles so that you maintain the object within the visual field on the retina. So you have a focus and maintain the object, whether you are moving your head up and down or right or left, you still have the object stable at focus on the retina. So this is done by coordinating the eye movement with the head and neck movement. Also, the vestibular system is important to maintain the head position. Why we need to maintain the head position? For example, if you are running or going upstairs or downstairs, your body is moving, and this movement you need to have your head at steady level, so preserve constant plane of vision so that what you see with your eye will not be shaking up and down with your movement upstairs or downstairs. The gaze or the vision is stable, and this is done by the medial vestibulospinal tract that reach to the neck muscles. So actually the neck muscles contract so that you keep the head stable, and the vision, what you are seeing, will be stable whether you are moving from side to side or up to down. So it maintains the head position. The vestibular pathway is very simple. It uses only two order neurons. This illustration shows you the connections with the cerebellum, because the cerebellum is a very important structure that controls the vestibular system. The signal of the movement of the body in space, or the position of the body, is sensed by the hair cells in the maculae of the utricle and saccule and the crista ampullaris present in the semicircular ducts. The receptor hair cells in this labyrinth, the membranous labyrinth, sense the change in the position and send the signal through the vestibular ganglion. So the vestibular ganglion of the vestibular division of its cranial nerve is the first order neuron. From there, the vestibulocochlear nerve sends its axon going to the vestibular nuclei, and the vestibular nuclei is present in the brainstem. From the vestibular nuclei, this is the second order neuron, will go to the vestibulocerebellum. Also, as you see, the vestibular nerve, some fibers from it goes directly to the vestibulocerebellum. The vestibulocerebellum, in return, affects the vestibular nuclei by the connection. If you recall the connections of the vestibulocerebellum, I mentioned it in the lecture of the cerebellum. These fibers run in the juxta-restiform body, which is the medial part of the inferior cerebellar peduncle. So again, the vestibular pathway is simple. It uses two order neurons. The first order neuron is the vestibular ganglion of the vestibulocochlear nerve, and it reaches to the second order neuron, which are the vestibular nuclei. They are four nuclei present in the brainstem. From the vestibular nuclei, it reaches to the vestibulocerebellum. This slide shows you another part of the vestibular pathway. This part is showing you the connections between the vestibular pathway with the medial longitudinal fasciculus. What is the medial longitudinal fasciculus? This medial longitudinal fasciculus is fibers located in the medial part close to the midline of the brainstem. Its function is to connect the motor nuclei responsible for supplying the muscles of the eye, the extraocular muscles, the muscles that are responsible for moving the eye. These extraocular muscles, as you have learned before, are supplied by the oculomotor nerve. So this is the oculomotor nucleus, trochlear nerve, and abducens nerve. So we have three cranial nerve nuclei. These three cranial nerve motor nuclei are responsible for supplying all the muscles of the eye that are responsible for movement of the eye. The fibers arise from the vestibular nuclei. How many vestibular nuclei you have? We have four vestibular nuclei. Superior vestibular nucleus, lateral vestibular nucleus, medial vestibular nucleus, and inferior vestibular nucleus. From these nuclei, the axons will reach to supply the abducens nucleus on both sides, the trochlear nucleus on both sides, and oculomotor nucleus on both sides. So this connection is very important through the medial longitudinal fasciculus to coordinate the eye movements. To coordinate the eye movement according to the signal coming from the vestibular system. There are also other connections coming from the vestibular nuclei. If you go to the receptor first, here are the crista ampullaris present in the semicircular ducts, and here is the location of the maculae or otolith organs in the utricle and saccule of the inner ear. These receptors sense the position of the body in space. They give the sensory signal through the vestibular nerve, vestibular ganglion, and then vestibular nerve to reach to the vestibular nuclei. From the vestibular nuclei arise the vestibulospinal tract. It's a connection between the vestibular nuclei and the spinal cord. And we have two types of the vestibulospinal tract: the medial vestibulospinal tract and the lateral vestibulospinal tract. The medial vestibulospinal tract is responsible of supplying the muscles of the head and neck, and the lateral vestibulospinal tract is responsible for supplying the muscles of the trunk and the limbs. So these tracts are extrapyramidal tracts, and they work to do very important function. The medial vestibulospinal tract is important for coordinating the head and neck movement with the eye movement. and the lateral vestibulospinal tract is important to maintain the posture and the balance. So by these connections, the vestibular nuclei are able to do the functions of maintaining the balance by the lateral vestibulospinal tract, maintaining posture and balance, coordinating the eye movement with the position of the body by the medial longitudinal fasciculus connecting to the cranial nerve nuclei 3, 4, and 6, and the medial vestibulospinal tract coordinating the head movement with the eye movement, and that's done by the medial vestibulospinal tract that is supplying the muscles of the head and neck. Defects can occur in the vestibular system, and these defects will show the findings as mentioned in this slide. The patient will come complaining of vertigo. Vertigo is a sensation of whirling. What's the meaning of whirling? The patient feels as if the world is spinning around him. So the patient feels as if everything around him is moving. حاسس ان الدنيا بتلف حواليه. This results from damage of the vestibular system or the cerebellar disease. The second defect can occur, labyrinthitis. Labyrinthitis is inflammation of the inner ear. It's called vestibular labyrinthitis or vestibular neuritis. It's due to inflammation of the vestibular labyrinth. That can occur due to microbes or toxic substances like alcohol salicylates. The patient has vertigo, has nausea. Nausea means غثيان. Horizontal nystagmus. Nystagmus is involuntary movement of the eye. Postural imbalance. ما يعرفش يظبط التوازن بتاعه with a tendency to fall to the side of the diseased labyrinth. يعني المريض لما يحاول يقف يقع على الناحية المصابة اللي هي فيها الإصابة اللي فيها labyrinthitis or vestibular neuritis. So tendency to fall ممكن يقع to the side of the diseased labyrinth على الناحية اللي فيها إصابة. Dysmetria يعني مش قادر يظبط حركة إيده. لما تطلب منه يشاور على حاجة ما يمسكهاش بالظبط، إيده تطلع قدام أو ورا يمين شمال اللي هو ما يعرفش يوصل للهدف. So it's dysmetria means inability to put the arm in the right position. يبقى إذا ممكن يعدي الهدف يبقى past pointing بدل لما يمسك الحاجة اللي قدامه إيده تحدف لفوق أو بعيد شوية. So it is overshooting يحدف إيده بعيد عن الهدف اللي هو عايز يجيبه ما يقدرش يمسكه على طول. يبقى إذا ما فيش ضبط لحركة اللمس. In this condition, the labyrinthitis, the hearing is not affected. Why it's not affected? Because it's affecting the vestibular part only. It's not affecting the auditory part. So the hearing is normal. In case of Meniere's disease that I mentioned before, the Meniere's disease is due to damage of the hair cells due to increase in the endolymphatic fluid pressure. As you already know, the hair cells are several. We have hair cells for hearing, for the auditory system. We have hair cells for sensation of the balance and equilibrium of the body, which are present in the semicircular ducts and the maculae of the utricle and saccule. All of them are hair cells, and all of them are present within endolymph. That means they have surrounding endolymph. If there is increase in the endolymphatic fluid pressure, it will damage the hair cells. يعني هيحصل إصابة في الاثنين. It's due to over production or malabsorption of the endolymph, and that can be due to the blockage of the endolymphatic duct. لما تراجعوا المحاضرة بتاعت structure of the ear هتلاقوا في السلايد الأخيرة فيها رسمة للإندوليمفاتيك duct اللي هي بتصرف الزيادة في الاندوليمف توصلها للسي اس اف للسب اراكنويد سبيس عشان الاندوليمف يتصرف مع cerebrospinal fluid. Or if there is periodic rupture of the membranous labyrinth. لو البريشر الموجود داخل الممبرانس labyrinth زاد هيحصل ليها رابشر، وإذا حصل لها رابشر إيه المحيط بالممبرانس لابرنس؟ المحيط بيها هو البيريليمف، فيحصل إن الإندوليمف يطلع من جوه لبره يروح مغرق إيه؟ البيريليمف. So the endolymph is rich in potassium، في نسبة بوتاسيوم عالية. البوتاسيوم العالي الموجود في الاندوليمف هيوصل للبيريليمف، ولما يحصل كده هيحصل ايه؟ depolarization للفيستيبولو كوكلير نيرف، يعني هيحصل excitation، هيحصل high signals، يعني هيحصل فيه shooting للسيجنالز، هيحصل stimulation للبوث components، للجزئين اللي بيكونوا الاوديتوري and vestibular nerves. So the patient will show vestibular effects and auditory effects of this depolarization. What will happen? The vestibular effects are vertigo، هيحس بالدوخة، الدنيا بتلف حواليه، nausea، غثيان، vomiting، قيء، horizontal nystagmus يعني حركة لا إرادية للعين، dysmetra مش قادر يظبط حركة إيديه، مش قادر يوصل للهدف اللي هو عايزه، and falling to the side of the disease، يعني إذا بيقع to the disease side، مش قادر يظبط توازنه، لما يجي يقوم او يمشي يروح واقع على الناحيه اللي فيها الاصابه. Also auditory effects as tinnitus، tinnitus طنين، يعني بيحس كده بحاجه بترن في ودنه، ringing in the ear and hearing loss، وممكن يبقى فقدان للسمع. ليه؟ كل ده سببه ان السبب الاساسي المشكله damage of the hair cells in general، كل الهير cells damage، whether these hair cells are receptor for hearing or receptor for the balance and equilibrium in the body. So this concludes the story of the Meniere's disease. And if you have any question regarding this lecture, please don't hesitate to ask me. Thank you. Concludes the lecture of the cerebellum. Please, if you have any question, don't hesitate to ask me. And thank you very much.